Good morning. Welcome to meeting number 3 of the House Budget Review Subcommittee on Health and Family Services. As a reminder, remote access is allowed to all meetings for the 2022 regular session. Members were provided a Zoom link to access the meeting remotely. The meeting materials were put online earlier this week and made available for downloading. At this time, we'll have a secretary call the roll.
Representative Bowling, Representative Fleming, Representative Frazier Gordon,
Present in the room.
Representative Gibbons Prunty,
Here in the room.
Representative Sheldon,
Here in the room.
Representative Weber, Representative Westrom, Representative Wilner,
Here in the room.
Representative Petrie, Representative Reed,
Here in the room.
Representative Mosier,
I'm here in the room.
and Chair Bentley.
Here in the room. So we have a quorum? Yes, we do. Okay, we have a quorum. Let's do business. Next, we have approval of the minutes from the January 19th meeting. Do I hear a motion? Motion. A second? All approve the minutes, say aye. Aye. Opposite sign, say the same. So the minutes are approved. First, looking out today, we had some people that have come in as guests. Does anyone have any guests out there to introduce? Representative Moser?
Thank you, Mr. Chair. I just looked out in the audience and I saw Commissioner Brian Painter is here with us. Thank you for being here. And I know that the Kentucky Medical Association is here today talking to a lot of folks. I don't know if we have anyone here in the room, but thanks for being with us today.
Okay. And I want to introduce Keith Watts. He's the county commissioner from Boyd County, back there in the middle. Thank you, Keith, for being here. I know how long you drove because I drive it every week. So, okay, we've had the approval of minutes, and before we begin with the presentations, for members participating remotely, please remember to mute your microphone. We have a full agenda with several presenters this morning. First, we have Commissioner Lee and Mr. Steve Bechtel from the Department of Medicaid Services to give us a presentation on the governor's Medicaid budget recommendations. Members, please hold your questions until after the presentation, please. And we'll take questions from members in the room and then questions for the members participating remotely. Presenters, please identify yourselves for the record.
Good morning. I'm Lisa Lee. I am the Commissioner for the Kentucky Department for Medicaid Services.
And I am Steve Bechtel. I'm the Chief Financial Officer for the Department for Medicaid Services.
Also in the room, Secretary Friedlander, being supportive of our fantastic Medicaid program, tremendous commissioner who've done such great work during the pandemic to support the healthcare industry in Kentucky. And we also have
Eric Lowry, Budget Director for Health and Family Services.
But we'll sit back.
And we're very pleased today to be here to talk to you about the Medicaid budget. And while this is definitely a team presentation, I'd like to acknowledge that Mr. Bechtel is actually the one who did the heavy lift of pulling all of this information together and worked tirelessly to make sure that we had a very good presentation to deliver to you today. So Sarah, if we could go to the first slide. So first, we just want to give you a little overview of Medicaid at a glance. We have currently, or as of December 2021, 1.6 million individuals enrolled in the program. As you can see from the numbers listed here, the bulk of those individuals, almost 1.1 million, are in the traditional category, which includes aged, blind, disabled, pregnant women, and children. We have another 590,000 covered under our Medicaid expansion. We have approximately 59,300 providers enrolled in delivering services to the population we serve. And our budget in 2021 was $14.6 billion in expenditures that included both administrative and benefit combined. Next slide, Sarah. So the budget for the Medicaid program has basically two categories. Our benefits budget, which is services delivered to individuals enrolled in the program. It does include mandatory and optional services, It also includes capitation payments that we make to our managed care organization and our non-emergency medical transportation program. And then we have some below the line items such as pharmacy rebates, Medicare premiums that we pay for individuals who are dually eligible. We also have some potential funding for additional budget requests. Our administrative budget consists of contracts. Those are contracts either for services to our individuals or some administrative assistance in operating the program. Includes state share transfers, advanced planning documents. Advanced planning documents are information technology related and are submitted to CMS in order to obtain funding for our information technology infrastructure. Our administrative budget also includes personnel, travel, and operating costs, and again, potential funding for additional budget requests. Next slide. So DMS receives various levels of funding from CMS, the Center for Medicare and Medicaid Services, based on the specific activity being conducted. For example, most of our administrative costs for personnel, certain contracts, we receive a 50% federal FMAP from CMS for those services. As we mentioned just previously, our advanced planning documents submitted to CMS, we receive 90% federal funding for technology services in the program when we are implementing, designing, and developing new technology infrastructure or new systems. Once those systems are implemented and in operation mode, we receive a 75 enhanced federal match for those operating costs. We also receive an enhanced match for our skilled professionals such as pharmacists and nurses. And as you can imagine, Kentucky is experiencing the same issues as our providers in trying to recruit and retain nurses due to the competitive nature and costs related to those services. So again, we are in the same situation as others trying to recruit and retain nurses in our program. Next slide. And this is just a scenario of our administrative budget, and it includes cost of living adjustments, implementation of a basic health plan, which is a plan that will serve as a safety net for individuals who are currently falling through the cracks. For example, they don't qualify for Medicaid and they can't get a product on the exchange. So we believe that basic health plan is going to provide a continuum of care for individuals in the Commonwealth. Administrative costs also related to the home and community-based services 10% FMAP reinvestment project are contained in the administrative budget, as well as costs related to further develop Medicaid information technology. Next slide. So the benefits budget is developed, as you can see there, it was a collaborative effort and a lot of work goes into projecting the budget. The collaboration, of course, is between cabinet officials, governor's office, and the state budget director. We use definitely historical data to develop managed care capitation rates. We also use enrollment projections to determine how much funding we will need going forward. And then the final product from this is the consensus forecast that makes up the benefit budget. Next slide. And as you can tell from our benefit budget, we do receive certain FMAP or medical assistance percentages from the Centers for Medicare and Medicaid Services for the individuals that we serve. Traditionally, Medicaid receives about 75 or 70% FMAP. As you can tell, there's a blended rate. You can see for 2022 going to 2024, that FMAP changes a little bit. Likewise with CHIP, typically it's around 80%. So the traditional Medicaid FMAP and the CHIP FMAP are flexible. Sometimes they do fluctuate, but the expansion population is always a 90% federal matching rate for that population. Next slide. And I will turn it over to Mr. Bechtel to talk about the next few slides related to our benefits budget.
Good morning again. Yeah, this slide is much like what the admin slide did. It is just basically showing you our actual spend in state fiscal year 20 and 21, our budgeted expenditures for 22, and what was in the governor's recommended bill of House Bill 285 for state fiscal year 23 and 24. The one thing that we will comment on is in 22 in the budgeted, we will be asking a current year appropriation increase, as you may already know, of $709.1 million federal fund appropriations. And the reason for that is the 6.2% FMAP. When we did the 22 budget, we assumed that the 6.2% FMAP would be ending, that the public health emergency would have ended. So we're just asking for those funds, those appropriations to be replenished. Next slide, please. This slide, first, before I go any further, we're very pleased with the level of funding in both the governor's recommended as well as House Bill 1. There are some differences. And one of the differences is if you'll look down through there, there's a comparison of the two bills. And the one issue that we're all aware of is that we had decreased slots in House Bill 1 versus what was in the governor's recommended for the Michelle P. waivers. But then that last line, HCBS waiver services funding initiatives, we received $48.3 million and $71.5 in 23 and 24 federal fund appropriations for those initiatives. And those initiatives included, those are in section 20, I believe, subsection 20 of the benefits budget in House Bill 1, substitute 1. And those, it's basically a 10% across the board rate increase for 5 of our waivers. One waiver that was excluded, I will say, was Model 2 waiver, but all the other waivers were to receive a 10% across the board rate increase for all services. We do have some concerns and challenges that we just want to be transparent with you guys and let you all know, and we're going to detail those over the next 2 slides. Next slide, please. The American Rescue Plan Act, also known as ARPA, is one-time investment. Currently, in order to draw in that 10% FMAP, we had to have, the department had to have an approved spending plan of how we were going to reinvest those funds back into the program. Before we were even able to draw in the extra FMAP, we had to have a CMS approved spending plan. And the one area of concern is that a 10% rate increase was not included in that spending plan. Just to let you know, we could do an amended spending plan, but then the state runs the risk of not having enough time to spend the approved funds once CMS, and if CMS grants that approval of using those funds. We're supposed to use these funds and utilize them by March, end of March of 2024.
And one thing I would like to add about the 10% across the board increase for those waiver provider types. Currently, there are some inequities in the reimbursement for particular services across waiver providers. So, for example, one provider may receive a different funding and for services for the same service provided in a different waiver. So we believe that a 10% across the board raise for those providers would also still result in inequities across the waiver types. And as you know, there has been a lot of focus on waiver redesign. We are still moving forward with waiver redesign activities, including completing a rate study and to develop an approved rate methodology by CMS.
And to go into that further, CMS requires an approved justifiable rate methodology. So when we do a 10% across the board, we're going to have to submit pretty much waiver resubmissions and amendments for every one of those 5 waivers. And a part of that, the CMS will require us to provide supporting documentation of the methodology used to derive the 10% figure. So how did we come up with 10%? Is 10% adequate? And like the commissioner said, CMS will be concerned about the parity that this 10% across the board, these types of increases do not address parity. So we have, to address the parity, we have initiated a rate study across all of our waivers, but that rate study is not scheduled to be completed until later this fall. And then the last thing on this slide is Appendix K, a part of a Section 20. It talks about taking the residential cost up to like 50% of the Appendix K rates. When Appendix K expires, some of these rates will decrease upon the end of the public health emergency. And when the public health emergency, the Appendix K sunsets. So the rate increases for these will not qualify for federal funding and will need to be supported with state general funds. Next slide, please. We did a little bit, we did a fiscal analysis on the 10% itself. And currently the language, like I said earlier, only provides federal fund appropriations just for this. And in order to fully implement the 10% rate increases, additional appropriation will be needed. We will need $80.4 million in state fiscal year 23, which is 40.1 in federal funds and 40.3 in general funds. 241.5 million in 24, which is 146.3 million in federal funds and 95.2 million in general funds. And this is assuming that CMS will allow us to use those ARPA funds, once we get that approval, if we can get that approval, like I said earlier, of using that in a spending plan, of an updated spending plan. The other thing is, without the increase described that I described above, the fiscal analysis indicates that the current funding that was provided in sections 18 and 19 of House Bill 1 for the SEL and Michelle P slots may be a little low. And this is why you got 43. What we feel is for SEL, we'll be able to fund 43 of the 50 slots in 23 and 34 of the SEL slots in 24. 44 slots of the Michelle P in 23 and 36 slots in 24. And this is the reason why. When you do a budget, you kind of come up with what the cost per slot is on these waivers, and you multiply it by the number of slots you're wanting to add. But with a 10% rate increase in 23 and a 10% rate increase in 24, that cost per slot also increases. So that we do not feel that was taken into consideration when those fundings for those additional slots were given. And again, I will mark, we can't say it enough. Current language in the House bill says that we will use the ARPA funds from to help fund these rate increases. But this type of rate increase was not included in the approved spending plan. I can tell you, I believe the spending plan was approved in September of 2021, and we've been working toward implementing those things since then. So that is a challenge, and that is a concern of ours. But one of the last things I'll say is what's not in House Bill 1 for Section 20. And it's those three words: pending CMS approval or upon CMS approval. If CMS does not approve the 10% rate increases, the way the language is today, we could be lawfully required to still proceed forward with these rate increases without CMS approval. And what that means, it puts the state at a great financial risk because all of those funds would be state funds only. So that was the last piece of the slide. And one other thing I will say is we're monitoring and we're aware of a lot of legislation that's coming through. Just want to point out that once when we see those bills pass, they got a price tag. If it's an increased rate, if it's an increase in rates or an increase in services provided by Medicaid, it's going to be a price tag to that. And the budget that we presented here today was what it is doing business as of today. So anything that you may see across your desk or that we may see that comes across, we are monitoring that it would require additional funding. And that we ask that when you take that into consideration when you're looking at those bills. And I'll turn it back over to the commissioner.
Yeah, and thank you for allowing us to be here and present our budget to you. We'd be happy to take any questions you may have.
Thank you, Mr. Chairman. So I guess my question is, you always have concerns. Who have you talked to? Have you talked to Chair Petrie or Reed or anybody in the Senate or about these? It sounds like you don't want that money because of the issues that might arise. And I understand that. I understand your concern from what you've presented. Who have you talked to try to rectify it?
I have been in contact with Chairman Petrie. He has agreed that we will continue to be on those discussions. He was, I believe, appreciative that we brought this to his attention. And I always, and want to say, appreciate how well we've been able to work together on these. And I didn't want to surprise anybody with this. So yes, we have let folks know.
A follow-up question, Mr. Chair?
Yes, Representative.
When will we ever see your all smiling faces here again?
Oh, not soon enough. We're with you on hoping we get past this Omicron variant and that you can see our smiling faces again, because we'd like to see yours as well.
Hi. Thank you, Mr. Chairman.
Thank you. Representative Wilner.
Thank you, Mr. Chairman. Yeah, thank you for the presentation, and thank you for the work that you do. This is a question about the waiver slots, and in the SMI task force, one of our main recommendations was a dedicated waiver for Medicaid waiver for supported housing for people with severe mental illness. And as you know, I'm sure you know, it's the only category of disabled adults that don't have a dedicated waiver or don't qualify for a current waiver. Is that issue something that's on your radar? Do you need legislative action for that to move forward, or is that something that can be handled administratively?
This is something that's definitely on our radar. Deputy Commissioner Leslie Hoffman is heading up this initiative, and she has been talking to CMS related to incorporating an SMI piece into one of our existing waivers. CMS believes that may be the easiest route to go. So definitely on our radar. And as we get more information, I would definitely be happy to give that information to this committee.
Thank you very much.
I think that was a very good question since we were, I helped chair that committee, yeah. Representative Gordon.
Thank you, Chairman. Thank you for being here with us today. And I just have a clarification question because I just want to make sure that I'm understanding it correctly. But other states, including Wisconsin, have implemented across-the-board rate increases. And did you claim that that was not a possibility? I just wanted to get some more information in that area.
It's not that it's not a possibility, it's that there are inequities in our waiver programs right now as it relates to reimbursements. For example, one waiver provider type may receive a higher reimbursement for delivering the exact same service in a different waiver, so that across the board 10% will result in continued inequities. In addition, CMS may not approve that 10% across the board until we have developed a sound rate methodology and they understand exactly what work and what components go into setting those rates.
Thank you very much.
And Commissioner, isn't the other clarification that under Appendix K, there is additional flexibility there, but we have to rewrite our plan for Appendix K to allow that. And some states have done that, but when Appendix K goes away, then you can't support that additional 10% moving forward. And so it's a nuanced response to your question, but those are kind of all the components that go into it.
Thank you, Mr. Chairman. I have a few questions and then a few comments, if that's okay. Okay. First, if you can you all just bring it over to us or send it over to us? Can you all provide the math to the 1915 rate increases and the estimates. If you all can provide that over to the Chairman Petrie in my office, if you can, I appreciate that. Another thing is, last spring you all testified CHFS needed a funding for the waivers. The House budget provides immediate funding and also demonstrates a longer-term commitment. Why are you against rate increases that will save our waivers at this time? You saw testimony all summer related to the plans related to the rate increases. Why are you now opposing it?
I don't think that we're opposed to rate increases. We want to make sure that the rate increases are fair and equitable across the board. And again, CMS has stated that we need an improved rate methodology before going forward with increasing those rates. So we are definitely not against rate increases for our waivers.
And let me be even more unequivocal than that. We are for rate increases for our waiver providers. We absolutely know they need the support. Absolutely. What we're saying is we need to be sure that the funding is there so that you don't put Medicaid or future budgets at risk. And we're just trying to give you what we see as the numbers, which we will supply you, on what those would cost.
All right, one more question. Even if HB1 adopted the governor's plan for the 1915C slots, do you all have the providers to provide for those slots?
Well, that's a really good question. And we do struggle with workforce issues, just like all of our other providers. We do have within our spending plan, our approved spending plan for the ARPA funds, we do have provisions in there related to workforce retention and recruitment. So we believe that as we go forward and those slots are filled, that we will be able to have staff to complete or to deliver those services as we go forward.
So is that a yes or a no?
That was a yes.
That was a yes.
There are long waiting lists. There are long waiting lists. We know the demand is there, and we believe the staff is there. But it is a good point. Personnel pressures across healthcare are going to present a challenge. I talked about childcare this morning, and it's the same challenge. That personnel challenge is a very real challenge.
And we do recognize that, and again, have a plan in our ARPA approved spending plan that has been approved by CMS to focus on recruitment and retention and training of direct healthcare workers, specifically for the waiver programs.
Thank you, Mr. Chairman. No more questions, but I do want to make aware that the rates are no longer tied to Appendix K. Committee Sub Number 1 fixed that problem. Thank you, Mr. Chairman.
Chairman Bentley, if you are asking questions, we can't hear you on
I'm
our
sorry.
side.
I'll turn this thing on and on. The administrative cost you brought up the other day, what was it, under 10% you told us? Of the whole program?
Administrative, yes, for the entire cabinet is yes, under 10%. Yes, sir.
I think that's commendable. You've done a good job. Any person else have a question? Any other person? Okay, thank you for your presentation. And next we'll have Commissioner Eldridge to provide a presentation on the budget recommendations for aging and independent living. Would you please identify yourself for the record? And again, members, hold your questions till after the presentation, please. Thank you.
Good morning, committee members. My name is Victoria Elridge, and I am the Commissioner for the Department for Aging and Independent Living, and it is an honor to join with you today. Next slide. Dale's mission is simple. It is to promote the welfare, dignity, and independence of older adults, individuals with physical disabilities, and adults in need of a guardian. Next slide. There are a myriad of individuals that we serve through our department. We serve, as you know, older adults, individuals with disabilities, individuals with dementia, adults under state guardianship, and caregivers. Next slide. This is a profile of what the current makeup looks like across Kentucky. You'll see here through the different comment boxes that currently there are 23% of Kentucky's population is age 60 or older. It is projected by 2030 that that will make up over 25% of our population. 1 in 7 senior citizens are food insecure at this time, and 35% of Kentuckians have a disability, with the main #1 disability being ambulation. And then again, over 1 million individuals are age 60 or older in Kentucky, and we are honored and proud to serve them. Next slide. You'll see here that our funding comes through federal and state general fund streams, and just wanted to give you an idea as to what federal funds are used to provide services to. Many of you are aware of our long-term care ombudsman program. This is a program that ensures the 35,000 individuals that are in long-term care have a voice, and ensure that their voice is heard as they receive services in skilled nursing and personal care and ICFs. Additionally, many of you all are very familiar with our senior citizen centers and our home delivered meal programs, and some of that funding does come through federally through the Older Americans Act. Additionally, we ensure that older adults have an opportunity to learn about disease and have strategies to prevent disease and also promote healthy living. We also strive to ensure that any older adult age 60 or older who's interested in returning back into the workforce has training opportunities and connections to do so. Additionally, we ensure that older adults that are living in their community have the supportive services that they need so that they can continue to live independently in their community. Supportive services include in-home aids, yard work, some home repairs, and transportation. We also oversee the state health insurance assistance program to ensure that individuals on Medicare have assistance to receive guidance on ensuring that they have the best prescriptions and at the most affordable cost. And then lastly, we oversee the National Family Caregiver Program, again, also through the Older Americans Act, to ensure that adult children who are caring for their aging family member with dementia have the services that they need, as well as grandparents that are raising grandchildren have the services that they need as well. Next slide. This is a list of the different state general funded programs that the Department for Aging and Independent Living oversees. You'll see here that we provide services for individuals with traumatic brain injury as well as to their family and caregivers. We certify assisted living communities. There are about 120 assisted living communities across the state. We also utilize state general funds to provide services for individuals with disabilities. Specifically, our personal care attendant program provides services to individuals with the functional loss of 2 or more limbs. So if you think of someone that's had a spinal cord injury, a stroke, or amputations. We also oversee the heart-supported living program and home care program that aim to provide services and our program of last resort. And what that means is that individuals that apply for these programs have to ensure that they don't meet Medicaid qualifications, and that if they do, they can receive the same services through Medicaid waiver. If not, then they can receive services through our state general funded programs. And then also we oversee a family caregiver program. This program is specifically aimed to supporting grandparents raising grandchildren only. We know that there are many grandparents who had planned on spending their retirement years enjoying retirement, and through life circumstances are raising their grandchildren, and we are here to provide assistance for them. And then lastly, we oversee the state guardianship program. State guardianship currently has about 4,500 individuals that are in our program, meaning that there is no one else available to make medical or personal decisions for them. And we have individuals across the state that serve as their state guardian. Next slide. These are some examples of Dale administrative oversight and support that we offer. You heard Commissioner Lee speak earlier to the home and community-based waiver. The Department for Aging and Independent Living is the administrator for this waiver. What that means is this waiver specifically serves individuals that are aging or have a physical disability. And so we ensure that all administrative services are met on this waiver, as well as we oversee all participant-directed services for all Medicaid waivers. 5 of the 6 have a participant-directed services option, and Dale oversees that. It is an honor to ensure that individuals who want to self-direct their own care have that opportunity. Additionally, we provide oversight for the State Independent Living Council. The State Independent Living Council is made up of individuals across the state that work closely with our Centers for Independent Living to ensure that individuals with disabilities have a voice and have community access and are able to engage in their community successfully. Also, we oversee the Alzheimer's Disease and Related Dementias Council. Many of you know of our newly established Office of Dementia Services, and this is one of the councils that we oversee to ensure that we are advising the Secretary, the Legislature, and the Governor on all matters related to dementia and related diseases. And then lastly, we partner with the Department for Community-Based Services and oversee the Elder Abuse Council. Next slide. So with all that being said, we know 2021 was a tremendous year, lots of ups and downs, and just wanted to take a moment out and share with you all some of the accomplishments within our department. One of the things we were able to do was to establish the first ever Health Occupation Students of America partnership with our area agencies on aging and independent living. What that meant was we were able to connect high school students who are interested in going into a healthcare field with individuals that are aging out in their community. This was significantly successful out in the far Western Kentucky district. There were high school students that were connected with seniors who were homebound, and they would make phone calls with them to connect and offer social engagement opportunities. Additionally, through this partnership, some of the local businesses donated funds or materials to help support this initiative. We have had the honor to go and present on this partnership opportunity nationally and to teach other states as to what we're doing here. In April of last year, I had the opportunity to go down to Purchase and connect with the Graves County High School and Mayfield Technical School. And we were able to go out, and some of the high school students were able to meet their senior citizens for the first time. This program has been so successful that this year, and moving into the second year of the program, Mayfield Community and Technical College has offered to start building ramps for individuals that are homebound as a way for students there to gain skill in building ramps, but also to ensure that our older adults are able to successfully get out of their home and engage in their community. We also implemented the Shot of Hope at Home within the Department for Aging and Independent Living. We are one of the first states to vaccinate homebound individuals with the COVID-19 vaccine. It is something I am so proud of, and it really took multiple partnerships, especially within the Kentucky Department of Public Health, but to ensure that our individuals that were homebound had a true shot of hope. Also partnered with the Kentucky National Guard to implement this as well. Additionally, we conducted our second annual Senior Hunger Summit. This past year, it was held virtually. As you know, as I shared earlier, 1 in 7 senior citizens are food insecure, and we are striving every day to make sure that our seniors do not go hungry. So we took time out to partner with leaders in the field to talk with some of our senior citizen center operators, as well as some of our other community operators, to see what we can do to help to address the food insecurity. We've also, as I alluded to, as we oversee the participant-directed services for 5 of the 6 Medicaid waivers, enrolled the highest number of employees and employers in participant-directed services. Again, this is an opportunity for individuals with disabilities to ensure that they have individuals that they can direct to assist in their care, whether it's personal care or community integrated services. And then lastly, as many of you know, we have been able to eliminate the wait list for senior meal services statewide. This was started in 2020, and we have been able to do so in through 2021. So we are so honored to continue to do this. And as the governor shared on March 13th of 2020, that any senior who wanted a meal could get a meal, and we have continued on with that. Next slide. So where does that leave us right now? This slide here gives you an example as to where we are with our current funding. You will note in 2020, about 61% of our funding came from general funds with an overall expenditure of $71 million. And you'll notice as we go through the slides that starts to change. In fiscal year 21, we were about 50-50 dependent on general funds and federal funds. In part, you'll see a significant increase in federal funding, and that is due to all of the different federal funds received with ARPA, CARES, FFCRA, a multitude of acronyms. And then in fiscal year 22 is really when it starts to change. You'll start to see that about 41% of our budget is reliant on state general funds, with the remaining balance falling to federal funds. This is in part due to the increase in funding that we received through ARPA to address food insecurity, as well as other monies to address health disease and prevention for our senior citizens, and as well as to ensure our grandparents raising grandchildren have the assistance that they need. And so you'll see in fiscal year 23 and 24 that the state general fund numbers do increase, but it is an exponential increase in federal funding, again, to ensure that our seniors receive the funding that they need to ensure that they have meals provided to them. Next slide. So speaking of senior meals, I know many of you all have many constituents that are a part of this program. Again, it is a program supported by federal and state general funds. In both current budget bills, the numbers are the same. There is a request for $7.2 million for the current fiscal year to continue to provide meals at an unprecedented rate, and then $29 million over the next 2 fiscal years in order to ensure. So I'm sure many of you all are asking, what happens if we don't have that money? What happens is that we have to, for about 2,000 seniors that are currently receiving meals, we would have to place them back on a wait list or find some other alternate plan for them to receive services. There would be a substantial increase in food insecurity as well as increased health risk. Many of you all know that our senior citizen centers are the cornerstone, especially in small communities and in our larger communities, for our seniors to go and engage in. Some of the senior citizen centers are open. Others have opted to close, and listening to senior citizens in their region that they just didn't feel safe, but they want to continue to receive that meal. And I also want to thank for a moment all of our senior citizen center operators and the volunteers. It would not be possible to deliver the exponential number of meals that we have delivered over the past year without our volunteers. So thank you. And want to leave you all with one last thing regarding senior meals. Maxine from Stanford, Kentucky, wanted you all to know that she loves receiving the meals and also seeing the smiling faces that deliver the meals to her each week. She said she appreciates the assistance that the center provides me, and she would not be able to make it without them. Thanks, Maxine. Next slide. There are a few additional funding requests in House Bill 285, specifically the Family Caregiver Program, as I had spoke to earlier, that covers individuals, older adults that are grandparents caring for their grandchildren. Additionally, I know that there were some questions around during the Secretary's presentation on the Office of Dementia Services. There is an additional funding request for that. Currently is operated through federal grant funds only, that those expire in 2024. Without those grant funds, the office will not be able to continue to operate. Additionally, there is additional funding request for our heart-supported living program. This is a program that provides support for individuals and families that have disabilities. Again, it is a program of last resort. You have to apply for the Medicaid waiver first and go that route if you are eligible. If you are not eligible, you can apply for the program. This program is phenomenal. It has impacted so many individuals. We also have 200 individuals on a wait list right now who are waiting for ramps, home modifications, car modifications, abilities to engage in different community activities to support their needs. And I will share with you that many of these individuals, because of the Heart Supported Living program, they're able to stay engaged in their community. And without it, some of them may have to go into long-term care. That is what they have shared with us. And then lastly is the National Core Indicators program to support aging and disability. This is a program that is held at the national level. Currently, our sister agency, the Department for Behavioral Health, Developmental, and Intellectual Disabilities, participates in this. And this is a quality support initiative, and it ensures that individuals receiving services, that they're receiving quality services, and allows consumers to have a voice. Next slide. So with all that being said, what are our department's goals moving into this year? And just want to leave this with you all in closing. We are working closely with the Department for Medicaid Services to establish PACE, its program for all-inclusive care for the elderly. Some of you all who have been here for a while know that the cabinet has worked so hard to try and get PACE up and going. Getting PACE was started under Governor Bevin's administration, and we've carried it through under Governor Beshear's administration. And fingers crossed, we will be opening up the first couple PACE centers later this year, and are so excited. PACE serves individuals age 55 and older that are dual certified Medicaid and Medicare, and just really excited for this opportunity. We are also developing and implementing our State Plan on Aging dashboard. Our federal State Plan on Aging was approved last year, and we are going to be implementing a dashboard to track the goals to ensure that we are moving Kentucky forward and being innovative and creative with many of our community partners to support our aging community. We also have received a $5 million Administration on Community Living grant to support individuals with brain injury. And so we are partnering with many of the universities and other associations across the state to launch a REAP program. REAP stands for Remove, Reduce, Educate, Adjust, Accommodate, and PACE. It's really focused on ensuring that students who have a concussion can return back to school and have the services that they need to support them as they go through their concussion management program. So we are really, really excited to launch this. There's about 15 other states that have this, and it has been very, very successful. A couple other things, the Department for Aging and Independent Living is partnering with the Kentucky Department of Veterans Affairs to strengthen our coordination and collaboration to support caregivers of veterans and veterans. In the event that the VA cannot support them to live independently, we have, as you've learned here, many programs that support older adults and can assist them in meeting their needs. And then lastly, it has been a true honor to come to you. I know my predecessors have shared with you all kind of the status of guardianship. As I had testified last year, we have a 50-50 match now with Medicaid and have been able to draw down additional funds to support guardianship modernization. We are so excited for the work that is going on for our Division of Guardianship to ensure that the 4,500 individuals that are across the state who have no one else to make decisions for them, that our staff are there to support them as we modernize the program. Next slide. So thank you all so much. I hope you all learned a lot about what goes on at the Department for Aging and Independent Living, and I'm happy to take any questions. Thank you.
Thank you, Mr. Chairman. Thank you for the work that you do. I'm very well aware of many of these programs in my district and have participated. My questions are really not related to the money so much as what caught my eye on pages 5 and 6, or the slides 5 and 6. It seems like there's several, like federal and state for grandparents raising grandchildren. How does that intersect with kinship care? or does it?
It does not. It states specifically that if individuals are eligible for kinship care, they have to go kinship care first. In being completely honest with you, the state funded family caregiver program has had significant cuts to it over the past couple years. It went from a $1.9 million program down to a $534,000 program. So in fiscal year 18, we were serving 632 grandparents, and this last fiscal year we served 200.
Thank you for the information. I have a lot of grandparents that I hear from that are trying to raise kids that don't have any support. So I wasn't even aware that some of these things were available. So thank you for that. And follow-up question?
Yes, ma'am.
I have a constituent that had a brother in guardianship, but there were family members to assist him. But could the pandemic have caused that situation to have happened for him to be put in guardianship?
I can't say for certain without knowing anything. I can share with you that many of the courts were closed and we're only hearing emergency cases. At the time, all courts have since reopened. And so that may have led to a delay.
Okay. Thank you. Thank you for your answers, and thank you, Mr. Chairman.
Thank you.
Ma'am. Representative Moser.
Thank you, Mr. Chairman, and thank you for your presentation. I just want to follow up on the grandparents raising grandchildren question. What are the specific services that are offered through Dale for grandparents?
Sure, that's a great question. So we offer supportive counseling and ensuring that grandparents attend support groups and are aware of all of the services available to support them in their community. In addition to that, there is a stipend that they receive. It's a $500 stipend that they receive. Many of the grandparents receive custody and don't know what to do, don't have bedding, clothing, the specific items to support individuals. And so there is a stipend that they can receive to purchase items to support their grandchildren.
Perfect. Thank you. That's really good to hear, because I too have a lot of grandparents who reach out to me with questions. So I'm really glad to hear that program is really being bolstered. May I ask another question,
Yes,
Mr. Chair?
ma'am.
On the dementia office, and I worked on that legislation the last couple of years, so I'm really happy that has been implemented and is funded. What is the budget request? I don't know that you covered it. Maybe I missed it.
So I can share with you specifically, the budget request is for $482,000 each fiscal year. It is specifically to ensure that the office continues to fund for our director. Our director is Jennifer Craig. She has started in October and has been just lightning in a bottle. She is wonderful. The legislation that was passed also stated that the office should have a director and administrative support person. There was not funding tied to that piece of legislation. We opted to only fund the director position and not to fund the administrative person. So it would fund the administrative person in addition to other research personnel that could help Kentucky move forward and really have a great idea as to what is needed to support this office. And I will just share with you all, in meeting with many of my other Southern counterparts, there are many other states that have a well-established office, to the point at which many of them have Office of Dementia Services regional coordinators across their regions. South Carolina is one that really stands out, as well as Georgia. So they were all really excited to hear that Kentucky is moving forward on this and are happy to provide any assistance. But again, we need funding for that to continue this.
Okay, if I may follow up on that.
Yes, ma'am.
When we were discussing the legislation and talking with the cabinet, it was my understanding that part of the reason for really getting this office up and running was to be able to apply for more grants. So I understand that you are operating under a grant that expires in 2024. Mm-hmm. Is the grant writing process also part of the funding stream?
So the grants that we would be going after would be to support families that are supporting individuals with dementia. What we are only asking for is for the personnel cost to cover that office. So the Office of Dementia Services Coordinator is actively working on seeking out other grant opportunities to specifically continue to provide services to individuals, as well as she is looking for grant opportunities to support her position. But her main goal right now, one grant that we do have is called Bridging the Gap. It is a $1 million grant to support individuals, specifically older children that are caring for their parents that have dementia, and helping them navigate the waters and ensure that they have what they need to live in their home. So again, the funding would be specifically for that position only. And then the director and support staff would go after other grant opportunities to support Kentuckians and their individuals with dementia.
Okay, I'm just trying to understand the $482,000 per year number, because when we talked about the legislation, the ask was, or the estimate was, approximately $150,000 per year for staffing that office. So I'm not exactly clear on what's happening, but I applaud your efforts. I know it's necessary. Hopefully we can keep that number from expanding and growing in our budget requests. And just one last thing, I'm very glad to see that the guardianship modernization is happening. I've had some personal care homes in my district who have had a really difficult time getting answers on guardianship from some of their residents, and it interferes with their ability to be paid to the tune of about 2 years. So very necessary. So thank you for your work.
Thank you.
Very good questions, representatives. Anyone else for a question? Okay. Thank you for your presentation, Commissioner.
Thank you, Chairman.
Okay. So for our final presentation, we have Director Alexander to provide a presentation on the budget recommendations for the Office for Children and Special Healthcare Needs. Would you please identify yourself for the record? And again, members, hold your questions till after the presentation, please.
Thank you, Ivy. You'll introduce yourself.
Bye.
Good morning. I am Ivy Alexander. I'm Executive Director of the Office for Children with Special Healthcare Needs. And with me this morning is Frida Whitfield Shaw. She's our Division Director of Administrative and Financial Services. Next slide, please. 1924, almost 100 years, the state of Kentucky has been providing services to children with special health care needs, the most vulnerable children in our state. Those children need more care than the average child. They're at risk for physical or developmental or behavioral conditions or emotional conditions. And within this agency, over these years, we have been able to provide care for them, and that continues. Next slide, please. In our state, in the state of Kentucky, we have 219,024 children that are defined as having a special health care needs. And that is basically a child who needs more care than the average child, or maybe they're on medications, or they're enrolled in occupational therapy, physical therapy, speech therapy. Whatever that is, we have 219,000 children. So we try to meet those needs through indirect care, indirect services, and collaborations with partners across the state. There's a subpopulation of those children, about 87,000 of those children. The Office for Children with Special Health Care Needs provides services to them through our population-based services and preventative health systems, such as our early detection and hearing intervention program, and also our early intervention in the KIPTA region. And then we have in a smaller population, about 6,000 children that receive services directly in our clinics. So it's a direct care service. And if you go to the next slide, please. So we have clinics across the state. We have 11 different districts. We collaborate with providers across the state. We contract with providers. Within our own office, we have nurses, we have social workers, we have administrative staff, we have audiologists in each of those offices. And then again, we collaborate in order to ensure that we're seeing all of those children or ensuring that the most vulnerable in our state are receiving services. We go to satellite locations, maybe a hospital, maybe the local health department. We want to try to be as close to those families as we can so that their children can receive services. Next slide, please. So you're probably familiar with our medical clinics. We have specialty medical clinics. We've had these clinics for years. But one of the things that occurred during the pandemic, COVID-19, is our telehealth services. So we shifted from telehealth. We had probably about 423 over a period of 6 months prior to the pandemic. To that, we looked at that same 6 months and it increased to over 1,200. So the telehealth visits increased. It allowed the families to be in their home and the provider in one location and our nurse care coordinator in another location. And care coordination is one of the things that's essential and very helpful for the families to ensure that that child is getting all the services that they need. With that shift to telehealth, the providers, the families, it was a great, it is, and it continues to be a great enhancement. Our providers are able to see the child in their own space. Our physical therapists can see the space. The families don't have to drive even 15 or 30 minutes. And as well, we have children in our autism clinic that are more comfortable in their home. And so there's a totally different setup basically for them when they're able to stay in their home and see the physician. So the telehealth program has really taken off. Next slide, please. So again, when we think about reaching those 219,000 children, we definitely have to have collaborations and contracts with other providers in the state. So these are some of the services that are provided through collaboration. You see them listed there. Next slide, please. It goes into another collaboration. So our autism clinics have been in place for several years. We do diagnostic clinics, treatment clinics, and we can screen as well. And those are just gap filling services. So there's not necessarily in every office, but they are in the offices where we felt that there was a need in the state. But one of the bigger programs that's coming about is our Extension for Community Healthcare Outcomes, or it's the ECHO Autism Project. And with this project, we have experts from across the state, from U of L, from UK, from Norton, and from also some providers, independent providers. They are the experts in autism care. The ECHO project, basically, those experts come together once a month for 1 hour, and they essentially empower providers across the state who join in virtually. They go through a didactic, program, and they, as well, they do a case study. So basically, a provider, like say a family practitioner in Eastern Kentucky who has a child that comes in with autism, they are empowered to treat that child and to work with that child and family versus having them on a waiting list for a referral. Next slide, please. This slide shows the population that we served over the last 2 fiscal years, fiscal year 20 and fiscal year 21. Again, with our specialty clinics, our audiology therapy services, the early hearing detection and intervention, and as well, our family-to-family health information centers. So this is also a key part, not only the care coordination, but we have family-to-family health information centers, which essentially connects one family to another family. So it's almost like a peer support system. Next slide, we will continue with the population served through our early intervention services. So this is a partnership with one of our sister agencies, and it's only for us in the KIPTA region. So in the Louisville office, we were able to do early intervention services to get children prepared for school, and it basically ensuring that there are no developmental delays. And if there are, then we can provide services to counteract that. Next slide, please. And so this shows our budget, our historical and our current and recommended. So from fiscal year 20 to 21 through 2024. So all of the services that we just mentioned, one of the things that I did not mention regarding our clinics is, of course, moving from paper-based to electronic. And so one of the things that we are doing is updating our e-prescribing, or beginning to do e-prescription. So there's various things that we're doing to upgrade and ensure that the services are still available for our most vulnerable. The next slide focuses in on fiscal year 2022 and how that money is budgeted. So we're about at 20 million, and about 75% of that is personnel, operating, the 12%, 13% through grants, and then very little, less than 1% on capital. Next slide, please. You have any questions?
Thank you for your presentation, Director. Representative Prunty has a question.
First of all, I just want to say kudos for your ECHO program. I think that's much needed, and it sounds like it's wonderful. Also applaud the telehealth services. But as a former physical therapist, I would just caution physical therapy, they actually need to see people because you can get contractures and things like that. So I don't know that telehealth is great for that over the long term. I understand the need for the pandemic, but I guess I would caution about that. But my question on the budget part, did it go down on slide 10? Did it go down in fiscal year 2021 because of the pandemic, or why the $2,000 decrease there?
Can you respond to that?
The 2,000.
Or 1,000, I guess.
Yes. Hi, Eric Lowry, Budget Director. The slight decrease had to deal with there were some one-time funding purchases included in a funded ABR for fiscal year 23. So not as much dollars were needed going forward into 24.
Okay. Thank you for your presentation. Thank you for the work you do. Like I say, as a former PT, it's very, very important. So thank you. Thank you, Mr. Chairman.
Thank you, Representative Prunty. You and I are the only two left, so I reckon that's all the questions, yeah.
Yes, we finally got to an agency today that I used to be over. So, that happens all throughout the cabinet, but this is one, and it's a fantastic organization.
It sure is. Thank you, Mr. Eric. We don't have any more questions. So before we adjourn, members, please note that we're scheduled to meet next week, Wednesday, February 16th. And now the next item is adjournment. So Representative Prunty, do you have a motion?
I do.
And I second it. So we're adjourned. Thank you all.